Hello everyone and welcome to our module on sensitivity and specificity. Let's start by talking about the incidence versus the prevalence of disease. So for example, if we were talking about diabetes, the incidence of diabetes could be described as 1,000 new cases of diabetes per year. When we refer to an incidence rate, we're always referring to the rate of new cases per some unit of time, like per year, for example. In contrast, if we talk about the prevalence of diabetes, that could be 100,000 cases at one point in time in a population. And so prevalence is different from incidence because prevalence is not assessed over a period of time. It's assessed at one single point in time for an entire population that's at risk of disease. So like I said, the incidence rate is the number of new cases divided by the population at risk, and it's determined for a period of time, for example, 1 year. And whenever you determine the population at risk, you always have to remember that patients who already have disease are not at risk of developing disease. So the population at risk is the total population minus the people who have disease. So for example, if there were 40,000 people that defined a certain population and 10,000 of those people had disease, and there were 1,000 new cases per year, the incidence rate would be 1,000, the number of new cases per year, divided by the population at risk, which is 40,000 minus the 10,000 who already have disease. So the incidence rate would be 1,000 cases per 30,000 population. If you wanted to know the prevalence rate, that's simply the number of cases that are present in the population at risk at a single point in time. And the entire population is at risk. So in this example, the prevalence rate would be 10,000 patients with disease for every 40,000 people who are at risk. Some other things to know about incidence and prevalence. For chronic diseases like diabetes, the prevalence is usually much higher than the incidence. There are new cases of diabetes every year, that's the incidence rate, but the prevalence, the number of patients living with diabetes at any point in time, is much higher because patients can live for years and years with diabetes. In contrast, for rapidly fatal diseases, for example with Zika virus infection, the incidence is similar to the prevalence because the number of patients who develop the condition as a new diagnosis, that's the incidence rate, is roughly equal to the prevalence rate because patients either die quickly or resolve the infection. If a new primary prevention program is launched, this will reduce both the incidence and the prevalence. For example, when new vaccines become available, they decrease the incidence of new cases of disease, and they also decrease the prevalence of disease. Vaccines are the classic example of a primary prevention program. And then finally, if new drugs are introduced that improve survival, this will have no impact on the incidence of new cases of disease, but it will increase the prevalence. For example, in heart failure, we have drugs like beta blockers and ACE inhibitors that help patients to live longer with chronic heart failure. This has no effect on the incidence of new cases of heart failure, but it does raise the prevalence because patients can live longer lives despite having the diagnosis of heart failure. The way that we know the incidence and prevalence of disease in a population is through the use of diagnostic tests, and that's what I'm going to talk about for the rest of this video. Diagnostic tests are used to identify individuals with and without disease. And in epidemiology, when we talk about diagnostic tests, we often use the concept of the gold standard. And the gold standard refers to the best available diagnostic test. Anytime a new test is developed, it's compared to the gold standard. We describe new tests based on the test performance versus the gold standard. Usually new tests are not as good as the gold standard, but we describe how close they come using various metrics. And the two most important metrics for describing the performance of a test relative to the gold standard are the sensitivity and specificity. So to understand the concepts of sensitivity and specificity, let's imagine that we wanted to measure the blood glucose level in individuals and use that level to determine whether the individual had diabetes or did not have diabetes. So basically, we want to use the blood glucose level as a diagnostic test for diabetes. In order to do this, we would start by identifying a group of normal subjects and measuring their blood glucose levels, and then we would identify a group of diabetics based on some gold standard test other than the blood glucose level, and we would measure the blood glucose level in the diabetics just like we did in the normal subjects. And then next what we're going to do is compare the blood glucose levels in the two different groups and see if we can use the blood glucose level to identify normal subjects compared to diabetics. So if we plotted the blood glucose level on the x-axis like this, and we plotted the number of subjects with each measurement on the y-axis, we would hope to get two curves for normal subjects and diabetics that look something like what's on the screen here. And if this happened, this would be fantastic because we would pick this measurement right here, whatever this blood glucose value is, and anyone whose blood glucose was higher than this, we would say they have diabetes. And if the blood glucose level was lower than this, we would say they were normal. Unfortunately, real life never works out like this. And more often what you get in real life experiments is something like this. The patients with diabetes tend to have higher blood glucose levels, and the patients who are normal tend to have lower blood glucose levels. But there is some overlap. There are some normal patients who have higher levels, and there are some patients with diabetes who have levels that are more towards the normal range. So in this setting, it becomes trickier to identify a cutoff for a blood glucose level that is diagnostic of diabetes, because for almost any value that we pick as a cutoff, we're going to have some patients above it who are normal and some patients below it who actually have diabetes. So the way we deal with this issue in epidemiology is we pick a cutoff point. For example, I'll pick the point right here. And then above that cutoff point, we are going to have a certain number of individuals who are true positives. These patients have diabetes and they are above our cutoff. But we're also going to have some patients who are false positives. That's all these patients right here. These are normal patients, but they're going to be declared to be diabetic according to our test, and therefore they are called false positives. And then by the same logic, below this cutoff point, we're going to have many patients who are normal. Those are called true negatives because they're negative by our test for diabetes, and they truly are negative. But then all these patients in here are going to be patients who are what's called false negatives. They are declared negative by our test. They don't have diabetes by our test, but they actually are diabetics. And so when we're talking about diagnostic tests in medicine and you pick a cutoff value, one of the first things you do is study a population of normal subjects and subjects with disease and identify the frequency of true positives, true negatives, false positives, and false negatives. And once you've done this, you can create a 2x2 table like what I've shown on the screen here. Patients with disease are along the top. Those who have disease are in the column on the left here. Those who do not are on the right. And then if the test is positive, those individuals go in the top row. If the test is negative, those individuals go in the bottom row. And so we can create our 2x2 table with true positives, false negatives, false positives, and true negatives. And we'll use the numbers in tables like this to determine values for a diagnostic test like the sensitivity and specificity. So let's start by talking about the sensitivity of a diagnostic test. The sensitivity is equal to the rate of true positives divided by true positives plus false negatives. It's basically calculated with the numbers found in this column right here. It's the true positives divided by all the patients in these two columns here. And so if a test had a sensitivity of 100%, that would mean that everyone who's declared positive by the test is a true positive, and there are 0 false negatives. There are very few tests that work like this, but that would be what a sensitivity of 100% would look like. And so let's go back to our graph of the blood glucose level on the x-axis and the number of subjects on the y-axis. And we have the normal subjects in blue and the diabetics here in red. We can pick different cut points along the x-axis for our cutoff of the diagnosis of diabetes. Above this cutoff, we're going to say that everyone has diabetes, and below this cutoff, we're going to say that everyone is normal. Well, if we put the cutoff right here, this would be a very sensitive test. Remember that sensitivity has true positives in the numerator, and we are going to capture all the true positives by putting the cutoff point where I've shown on the slide here. We're not going to miss any of them. So this cutoff point here is going to maximize our sensitivity. And notice that if we put our cutoff point here, then anyone who is below the cutoff, in other words, anyone that we declare normal, is definitely normal. And so we'll come back to this point later, but sensitive tests are great for ruling out disease, because when a sensitive test says you do not have disease, then you're definitely over here, definitely in the normal area of the graph. On the other hand, when a sensitive test says that you do have disease, it means you're somewhere over here. You could be some of these normal subjects here, or you could be a diabetic. It's hard to say. The main utility of a sensitive test is for ruling out disease and declaring subjects normal who are negative according to the test. Now consider what would happen if we put the cutoff point right here. This would be a test with a very low sensitivity, because the number of true positives that we're going to capture is only this group here. We're going to miss this large group of true positives, and therefore we would have a low sensitivity if we used a test with this cutoff point right here. So now that we've talked about sensitivity, let's talk about specificity. So specificity is equal to the number of true negatives divided by the true negatives plus the false positives. I told you before that sensitivity involves this column, all the patients who have disease. In contrast, specificity involves this column, it's all the patients without disease. And you can think of specificity as answering the question, how good is the test at picking up the true negatives? If a test were 100% specific, then it would identify all of the true negatives and there would be 0 for false positives. This would essentially be a test that is performing identically to the gold standard test. So back to our two curves for normal subjects and diabetics. If we were to make the cutoff point for diabetes right here, this would represent a very specific test. Remember that the numerator for specificity is the number of true negatives, and by making the cutoff point here, we maximize the true negatives because all of the normal subjects are going to be below our cutoff point, and therefore they will be deemed negative by our test, and so we will have a very high number of true negatives. Notice also that when a specific test is positive, meaning that a test is above the cutoff point, that's very good at ruling in disease because a positive specific test means it's very likely you have a patient who has true disease who is truly diabetic. On the other hand, a negative specific test is hard to interpret because patients who are negative by a specific test could represent normal patients but could also represent some of the diabetics who are going to be negative by a very specific cutoff point for a diagnostic test. And then if we move the cutoff point way down here, this would be not very specific. Once again, true negatives are in the numerator, and here we're capturing some true negatives, but we're missing a lot of the true negatives, a lot of the normal subjects. So we would have a not very specific test if we set the cutoff point here. So on your board exams, they will sometimes ask you to calculate the sensitivity or specificity. And this is very easy to do if you just set up a 2x2 table like I've shown on the screen here. So for example, they could tell you that the results below are obtained from a study of test X on patients with and without disease A. What is the sensitivity of test X? So when you're asked about sensitivity, you're always dealing with this column of patients here, the patients who have disease. And the sensitivity is the true positives, which is 25, over all the patients in this column. So in this example, it would be 25 over 100 or 25%. And then they could also ask you for the specificity of test X. The specificity involves this column here. It involves the patients who are negative for disease. And it's the true negatives, which would be 10, divided by all the patients in this column, which is 20. And so the specificity of this test would be 10 over 20 or 50%. So we've already talked about this, but I want to emphasize this key point because it's very important. Tests that have a high sensitivity are good at ruling out disease, and tests that have a high specificity are good at ruling in disease. And many people remember this by the mnemonics SNOUT and SPIN. And so if we go back to this slide and look at our very sensitive test, this is good at ruling out disease. If this test says that an individual is negative for disease, then that means they're very likely to be a normal subject, as shown by our difference between normal and diabetics based on the gold standard. And if we go to this slide and look at our very specific test, when a very specific test is positive, that means the patient is very likely to have disease, because when we set the cut point here to be very specific, all the patients who are positive by our test are going to be patients who have diabetes based on the gold standard test. So we can apply these principles of sensitive versus specific tests to the concept of finding a rare disease in a population of patients. When you're trying to do this, you want to screen with a sensitive test. Because it's a rare disease, most of the people you screen are going to be negative. And with a sensitive test, when the test is negative, that's reliable because it's a sensitive test. And as we just discussed, sensitive tests are good at ruling out disease. So by starting with the sensitive test, you can exclude many patients who do not have disease and they won't require further testing. For the small number of patients in whom the sensitive test is positive, you can follow up that sensitive screening test with a specific test. As we've already talked about, specific tests are most useful when they are positive because they indicate a high likelihood of disease. So you can use a specific test to sift through all the false and true positives identified by the sensitive test and come out with a small number of patients who's very likely to have the rare disease. Another way to think about this is you want to use a sensitive test when you don't want to miss cases. Remember, sensitive tests capture lots of true positives. All the true positives are going to be positive by a very sensitive test. Although you pay a price for this, you will also have many false positives, but importantly, you won't miss cases. So this is useful when you're screening large populations for severe diseases where you don't want to miss cases. For example, we use mammography for screening in breast cancer because it's a severe disease that we don't want to miss. If a woman has a negative mammogram, there's a very good chance she does not have breast cancer. If the mammogram is positive, though, that could be a true positive or a false positive, and she needs further testing to determine whether or not she truly has breast cancer. And so that leads to my second point, which is you can use specific tests after sensitive tests to confirm the diagnosis of a severe disease. So in breast cancer, we use breast biopsy after a positive mammogram. That's because biopsy is a very specific test, and so we use it after the sensitive screening test of mammography. Now, sometimes with a diagnostic test, you want to pick a cutoff that maximizes the sensitivity and specificity. In other words, you want the test to have the highest possible combination of both sensitivity and specificity. And so the place on the chart, as shown here, that does that is the midpoint. If you pick a cutoff here, your test will have the highest combined value for sensitivity and specificity. And a related point is that the degree of overlap of the two curves, the normal patients and the diabetic patients, limits the combined sensitivity and specificity that you can achieve with a test. So for these two curves on the left, you're going to have a lower combined sensitivity and specificity compared to the two on the right. And that's because there's more overlap of these two curves and there's less overlap here. The smaller the degree of overlap, as shown here, the higher the combined sensitivity and specificity that you're going to be able to achieve with your test. And then the final point I want to make is that sensitivity and specificity are characteristics of a test, and they remain constant no matter the prevalence of disease. In another video, I talk about positive and negative predictive value, which can also be described for an individual test. But the positive and negative predictive value are heavily dependent on the prevalence of disease, and that is not true for sensitivity and specificity. They remain constant no matter the prevalence of disease in the population that you're testing. To make this very clear, let's imagine that we have a test called test X with a sensitivity of 80% and a specificity of 50%. And let's imagine that we want to use this test on group 1, which has a disease prevalence of 80%. And so because disease prevalence is 80%, the number of positive patients in the population is going to be 80. That's going to be the total number of patients in this column here. And the number of disease negative patients is going to be 20. This represents 80% of the population being positive. Now, because the test has a sensitivity of 80%, for these 80 positive patients, 80% of them will be true positives. That's the number 64 here. And 20% will be negative. That's the number 16 here. Also, because the test has a specificity of 50%, 50% of the 20 disease negative patients are going to be true negatives. So we'll put 10 here. And the remaining 10 will be here. So I've filled out this table based on the sensitivity and specificity of our test for a theoretical population that has a prevalence of 80%. Now over here I've done the same exercise with a prevalence of 20%, so we only have 20 patients who are positive for disease and we have 80 who are negative. But once again, using the test sensitivity and specificity, I've filled in all the values for the 4 quadrants on this table here. And so if we take the numbers from this table for group 1 and we calculate the sensitivity and specificity, it works out to 80% and 50%. And it should, because we used 80% and 50% to decide how many patients to put for true positives and true negatives. And over here in group 2, where the prevalence is 20%, if we calculate the sensitivity and specificity, once again, we get 80% and 50%. And that should be the case because we used the 80% and 50% sensitivity and specificity to decide on the number of true positives and true negatives. So the point is, and the reason I've gone through this exercise, is simply to show you that no matter the prevalence of disease, whether it's 80% or 20%, when you do a 2x2 table, you will always get results that give you a sensitivity and specificity of 80% and 50%. And that's because sensitivity and specificity do not depend on the prevalence of disease in the population you are testing. As we will see in another video, this is not the case for positive and negative predictive value. Those numbers change depending on the prevalence of disease in the population. And then I'll finish with one slide and talk about the language that's often used in board questions to describe sensitivity and specificity. If they tell you a test is negative in 80% of people who do not have disease, you should be aware that they're describing the true negatives and the specificity of the test. Patients who do not have disease and who test negative by a diagnostic test are true negatives, And the percent of patients that are true negatives is the specificity of the test. And so this is just a fancy way of telling you the specificity of a test. Along those same lines, if they tell you a test is positive in 50% of people who do have the disease, then they are describing the true positives and the sensitivity of the test. People who do have disease who test positive by a diagnostic test are true positives. And if true positives are 50% of the population, then that means the test has a sensitivity of 50%. And so students are often tripped up when reading questions about sensitivity and specificity because the language they choose doesn't explicitly state this is the sensitivity or this is the specificity. So make sure you understand sentences like the ones I've written on this slide. This is how things are often going to be described in a board question. And that concludes our module on sensitivity and specificity.